Thank you, Abhijit. Good morning, almost noon, all of you, and I thank IDEC for inviting me and our UDF team for the ZAP program. So you have just heard about initially history taking an examination, then high risk or categorizing your patient in high risk. What was important in all these things is what Dr. Abhijit mentioned about the need of a multidisciplinary approach. So just, is there any surgeon around in this audience? No, all are physicians. So my topic today is podiatric procedures, or basically what as physicians we can do in our clinics. I will divide my list of podiatric procedures that we can do in our clinics in these two categories. The first being nail trimming, ingrowing toenails, interdigital maceration, and callus trimming. Then comes your foot care and footwear in the center, which will be taken in detail when the offloading part will be covered. What is important is the lower part, corn excision, debridement of ulcers, and cast applying a plaster cast in our patients. These two are OPD procedures, podiatric procedures that can be done, but mostly these are done by the surgical side. Why I tell you this is where I practice in Jupiter, we have these two diabetic foot clinics. On the left side is my side, that's a physician side, and on the right side, which you see on the lower side, is the surgical podiatric clinic. So we have two clinics, and that is why the differentiating part, the first three things are done on the physician side, which all of us can do on a very, on almost an OPD basis, where the lower three parts are done mostly in the surgical podiatry room. But all of these are OPD procedures, mind you. So let's start with few procedures. Nail trimming, which is really, really simple and very important. We see number of nails, different nails coming in our clinics, and we encounter many patients who are old and cannot bend and cut their own nails. They cannot see their own nails, and then that's why the nails keep on growing in a haphazard manner. And on the other side, there are those who can cut their own nails, but because of their thickness, because of their irregularities, they cannot cut in a proper way. So nail trimming is a simple procedure that can be done by all of us, or even you can, we have taught our diabetes educators or assistants who are there in our clinics what all it requires is a good positioning. This is really important. It's easy to cut our own nails, but try cutting someone else's nails. With a regular nail cutter, it is really tough, but with a nail clipper like this, which is easily available on Amazon, a lot of these clippers are available, and right from ranging from 600 to 1500 or to 2000 rupees, depending on what kind do you want. But simple bone cutters, are sometimes small bone cutters are used, or they are good for cutting hard nails. So that can be available from the surgical stores, medical surgical stores. And what is important is the way you cut your nails. We have put this in our clinics. All of us know, we tell our patients that they need not go very near to the skin while cutting the nails. There has to be the nails has to go beyond the fleshy part of our toes. But when you are cutting, or when your assistant is cutting, they also need to know the same thing, that we need not cut the corners, don't go on both the sides. It has to be cut straight across. This is possible with these kind of nail clippers, and it's very tough to do the same procedure with a regular nail cutter which we use for our home use. A good positioning is important. You need one of those chairs, if not, at least a stool where a patient can keep your foot on in front when he or she is sitting in front of you. With this, a good light, because many times you see that the nails are attached to the skin beneath. So if you don't notice that, and if you just cut the nails without seeing that skin part, you might cause a bit of bleeding. It's not something which will cause a lot of harm, but unnecessarily you will have to then start dressing that wound. Hand disinfectant, very important when you are cutting or when your assistant is cutting someone's nails or trimming someone's nails. It is a good procedure to wipe all the nails off with our hand sanitizer like Sterilium or any one which you are using. Gloves is important, and last but not the least one, after you cut the nails, they are supposed to be filed with a filer, because otherwise the edges from these nail clippers, when you cut the nails, they are very sharp. The edges of the nails remain very sharp. That might hurt the patient inadvertently. So these are small, simple things which we learned over a period of time by trial and errors, and what mistakes we did. I'm trying to tell you these, so might help you a lot. Lastly, disposal of the nails are done in the yellow bag always. So if you guys have, any one of you have in your clinic medical waste disposal, they are always thrown in the yellow bags. You have 3 bags, right? Black, yellow, and red. So the gloves go in red, and the nails always go in the yellow bag. Again, I know it might sound very simple, but these are simple things which are important in our day-to-day practice. Coming to your ingrowing toenails, more than 10 million cases per year. It mostly affects the great toe. We all have seen this, and it accounts for almost 20% of our podiatric cases. Why does it happen? Because of improper cutting of nails. Now, when the patients do it on their own, they try to, as I told you right in the beginning, they cut the corners. This cutting the corners of the nails make the nails go inside on the edges and cause ingrowing toenails. Tight, narrow toe boxes in many shoes, which males as well as females wear nowadays. Hyperhidrosis or poor foot hygiene. Fungal infections. Many times none of these are there, but you have a family history of ingrowing toenails. And that's also a very common scenario. Repetitive trauma, and last but not the least, abnormally shaped nail bed. Why is this important? Because you need to first stratify these ingrowing toenails into mild, moderate, and severe. The mild part can be managed by our side as a physician from our side, and moderate to severe ones can need surgical intervention. These two are, mind you, OPD procedures, but normally we would not do all these procedures in our clinics. So, as I told you, I then referred him or her to the podiatry the surgical side of a podiatric clinic, and then they do this needful. The differences is mild is just an erythema or mild pain, edema around, but no pus or discharge. In moderate, you have some discharge at the edges, and when you have granulation tissue, it's a severe kind of a ingrowing toenail. So what do we do in our clinics? As a physician, you can do one of these things. Very simple procedure, trust me, and it helps a lot to your patients. Best is you can use antifungal local applicants. There are nail paints available with your medicals. You can ask with your chemists. Local nail antifungal nail paints. A common trade name is Nail On, which they need to apply once a week. It's a transparent one, so even males can apply that, and there's no color to it. And as far as females are concerned, they can apply whichever nail paint they want over this thing. So it's a very practical thing. They have to do once a week for at least 6 months, so that even if there is a slight fungal infection, it doesn't recur. You can use one of these procedures. One is, if you can lift the corner of the nail with either a forceps or with your hand, you can just pull it up. Then you can put this cotton wisp thing. You can teach your patients. We do teach our patients to insert a cotton wisp in between the toe and the skin. Over a period of 1 to 2 months, gradually the nail which grows, it becomes flattened, and then the ingrowing toenail is almost obliterated. The risk in this thing is, since cotton is a hygroscopic material, the chances that it will get wet and cause fungal infections are very severe. So you need to teach the patients that if it becomes wet, immediately remove it. They need to take care that they don't wash their feet again and again throughout the day. They do this procedure after a bath so that the nail is a bit soft, and then just insert a small cotton wisp in between the edge of the nail and the skin. The second one that you see on the left side, over here, this is nothing but it's called as a big name for it actually. It's a gutter splint, but it is nothing but an our IV set. So you cut your IV set, the tubing of the IV set. You cut the tubing of the IV set into this much portion. So a simple IV set can be used almost 15-20 times. You give it, we give it to our patients. We teach them how to do this. They cut it, slit it across. As you can see, you can see the slit in the IV tubing. All you have to do is insert it inside. It's a rubber tubing, all of us know that. It's easy to insert in between the nails. It doesn't cause, as what I mentioned about the cotton thing that causes fungal infection. The chances with this are very, very less, because as it will not retain any water. The only part is, it normally is very loose if you try doing it, meaning it comes off very easily when they start walking, because when you start walking, the skin and the nail, they move a bit, and that's how it just comes off. So what we did in our patients is we asked them to do it at night and then wear a sock and sleep. At least every night if they do this, it might take a long time, more than 2-3 months, but then the nails gradually straighten away. At least the pain part goes away, and the nails eventually start growing in a proper fashion. And last but not the least, if you cannot lift the edge of the nail on your own, you try it on your patients, or if you do not have any gutter where you can put either this or this, then you can do something which is a taping, which is a simple procedure. As you can see over here, you can use a micropore tape. That also doesn't require any special tapes. The micropore is a trade name. It's that paper tape which can be easily removed. All you have to do is press on the side where it is going, the skin part, attach a tape over there, so that now you have kind of offloaded the nail and the skin, rotate it around the thumb or the toe, and tie it on that side. See, you can see this. So first you press here, I press this, attach the tape here, rotate it around it, and then just tie it. You do it once every day, again after a bath, because then again it will not become wet. And the moment it becomes wet, it also has to be removed, because this also is a hygroscopic tape. It's a paper tape. Why paper tape? We tried other ones as well, but this is easy to remove. You know, these are painful and very tender areas. Now, when we attach the other tapes, the ones which we used when we were studying, they do attach very firmly, but while removing it pains them every time they remove it. This hardly pains. It's easy to remove also. So basic thing, again, moderate to severe, I normally send it across to my surgical counterpart, Dr. Parina Bajaj, who sits with us. And it's also an OPD procedure. They have to do nail removal or a lateral nail bed removal. It's also an OPD procedure. But then I would not go into that, because as I just asked you, we all are physicians over here, and we would not like to venture in that area much. Coming to cons and calluses. Basics, you need to know the difference. What are cons and what are calluses? Okay, I have mentioned over here, but for all practical purposes, most of the times you have calluses on pressure areas. You have calluses where your patient's foot is being hammered again and again against the floor. So you have calluses typically over here, at the heel, at the toes, if you see over here. Whereas cons can happen, this is a pressure bearing area, I agree, but this is non-pressure bearing area. So cons can happen and do normally happen on a non-pressure bearing area. The other differences are this, you can read those, I will not go into those, but But practically, see, this matters a lot for us. Again, I'll tell you, because why? Callus trimmings, from our side as a physicians, we can easily do it, because I'll come to that. Whereas when you do a corn cutting, you cannot do it half-heartedly. You cannot just scrape off the skin on the top and say that I have removed the corn. The corn have to be gone deep into the corn removal has to go deep inside with the conical. We were all taught this in our surgical postings during when we did our MBBS, and some of us have even done it. So we know that until unless you don't remove a proper conical part of the corn part, it's an incomplete thing and it will recur again and again. As far as calluses go, it is also a recurrent thing because of the pressure area. But if you, if you do it repeatedly every 3 to 6 monthly, gradually the skin that develops is less hard than what it is as this in the previous issue. So it is painless, it is bloodless. So as far as we physicians, we don't want any blood in our clinics. So yeah, it can be done easily by our assistant as well, and that's what we do in our clinics also. I have taught my diabetes educators and assistants how to do it. It reduces hyperkeratinization. You have to repeat it again and again because these are pressure changes. So it will happen again when the patient walks. What is important in this case is footwear. That will be covered in the next topic. But as far as if the patients who already have these things, we need to take care of this. Now, how do you do this? How do you train someone to do this? You can practice with one of these. And we have actually done this. I mean, we gave sweet lime or canoes. There are some, it's a mix between an orange and a sweet lime and pomegranate. So if you see, these are just graphical representations, but this is how they should, until and unless they learn to do this, meaning the skin doesn't come off, there is no juice coming out of that fruit. This is the time when that assistant is ready to do callus cutting. Okay, when they do this, it's still time. You do practice more. We tried all this thing in our patient. I'm telling you again and again that these are the mistakes which we faced or hurdles of which we faced, and it's easy for you to do this. Try doing this. This is gross, this is midway, and this is good. So when your assistant or when you can do this kind of scraping of your fruit, that is when you are ready to do callus cutting. It's easy. Trust me, it's just 1 or 2 sittings. Okay, coming to interdigital macerations. This is also a common thing which we see. So what do you do for this? Sorry? Yes? Done. That's all you have to do. Don't do anything else. What is important in this thing? What the important part is the last sentence. Second last. It is confused with tinea. It is not fungal infection. So do not apply antifungals in between these things. How do you differentiate that? By most commonly is itching thing. But you will, over a period of time, you will see these, now when rains, you will see a lot of these in our patients. All they have to do is, as Madam mentioned, dry and separation. That's all that you do, and trust me, you don't require any ointment for this. I used to give a lot of antifungal, those combinations that we have of antifungal, antibacterial, and some steroids also in that. It was a common practice. I used to just write blindly these things and give it to my patients. But trust me, it in fact macerates it more. So all you need is, how do you do that? You have these toe separators, which are silicone toe separators, easily available by Dr. Scholl's, in fact. In fact, these are there even in Bata shops. One of these Bata shops also I saw those things. But it is easily available with your pharmacy or your medical or surgical store. So toe separators and silicone toe rings. Now, coming to practical points amongst these two, toe separators very tough to keep in place. I mean, I have tried this in most of my patients, but very effective. Although it's very, very tough for the patients to keep it in place and walk. Now these are good for patients who wear shoes regularly. So they should buy a white toe box. The footwear part will be covered, but for them they should specifically buy a white toe box footwear, and then use your what is this? Sorry. Yeah, toe separators. Then they remain in place. Just by doing that, and every time they wash their feet, they are supposed to dry them with a cotton cloth, compulsorily in between all the toes, not just the affected interdigital space, but all the interdigital space. Dry them, keep it as a habit for the patient. That's what we tell our patients, and that's how you treat, and that's how you prevent these from occurring. The easier part is this, although not very, very effective, I would say, because if you see still there will be crowding. This is good for crowding of toes. Many patients of us have crowding of toes. To realign them over a period of time, your toe separators work better. But otherwise, in a normal diabetic patient who is not wearing shoes, I think toe rings are much easier to. Wound debridement, I'll not go into detail. As I told you, these are OPD procedures, but trust me, only the chemical part of it, we do give sometimes hyaluronides ointments, which are branded available, along with your antibacterial ointments, or sometimes we scoop it off if you see a biofilm. It's a topic in itself, so I'll not go into detail, but it's more of a surgical part that normally a surgeon or a surgical counterpart in your clinic or your hospital would rather do it. And last but not the least, plastic cast. Very important. You will know now in your next lectures that offloading is important. Different kinds of plastic casts are available. This is a standard one which we all know of. There are those fiber plasters, and there's different ones which are easily applicable by us and which are easily manageable by the patients. Again, it's an OPD procedure, I agree, but as physicians, I don't do it. That's why I don't know how many of you would be interested. If you are interested, it's worth doing it to offload your patient's foot, or get one of your surgeon friends to get it, help you with this thing, or orthopedic ones. This is my last slide, trust me. Why am I know I'm overshooting by 5 minutes, I'm sorry, but why am I saying all this? You see this callus, okay? It's a pre-ulcerative state. If this was a patient who went through all these stages, and it's our fault, meaning callus was not treated well, infected, got cellulitis, then without doing an angio, it was scraped somewhere. So my point is, when I mentioned all these procedures, it appears to be easy and doable, and just don't start doing it in all your patients from tomorrow. You need to evaluate, you need to know what Dr. Alka told you about history, you need to know about the risk stratification, what Dr. Abhijit told you. Find out whether there is good blood supply before you are doing all these procedures. I mean, it appears easy. Find out the blood supply, which is a need for all our patients before doing any procedure, and then go ahead and do it. Otherwise, what happened is, you can see in this patient, it ends up in that. Okay, thank you. So